attitude that will lead to better practices. And that it so many there are so many
Hello.
pharmacies to expect. I just thank you.
Thank you very much, Dr. Okwo. I want to appreciate you for the service you've done to PSN. Distinguished pharmacists, Mr. President, all protocols observed. Like our chairman have said, the topic today is about best practices in community pharmacy. Do it, know it. I will believe that at the end of the session, participants should know the various practice options in community pharmacy and the best way to go about them. I'll be looking at this topic from the perspective of what is a community pharmacy, who is a pharmacist, who is a community pharmacist. It's like housekeeping, what we know already, but let's remind ourselves. Then we'll talk about what is the scope of community pharmacy practice, what are global best practices, applying the best practices to Nigerian context, challenges to the community pharmacy, and opportunities to overcome them. Then collaboration, stroke forming a team to hold each other accountable, dealing with the menace, stroke challenges of patent medicine vendors, and project patient-free zones, stroke city. Some of the panelists will be taking some of the subtopics. Yeah, the mic is vibrating. It's echoing. Can you hear me there? Use the mic. Okay, take it far away from my voice. All right. What is a community pharmacy? Community pharmacy, also known as drugstore, can be found on the high streets, at the heart of the most rural villages and in the center of most deprived communities. Many are open long hours when other healthcare professionals are unavailable. Community retail pharmacies are broadly divided into the mass retail chain and independently owned pharmacies. The traditional role of the community pharmacist as a white coat-wearing healthcare professional who dispense prescriptions written by doctors has expanded. In recent years, community pharmacists have been developing clinical services in addition to traditional dispensing role to allow better integration and collaborative work with other healthcare professionals and social care providers, and more importantly, to deliver better patient outcomes. Community access by patients. Community pharmacies are easily accessible. They are the most accessible healthcare professionals. Give it up for pharmacists. We are the most accessible healthcare professionals. Even here in Nigeria, in the United States, Europe, and Australia. It has been proved. With many community pharmacies located where people live, shop, and work. In the state of Georgia, where I practice, there are about 2,100 community pharmacies in 2015, according to Drug Digest. And in the United States of America, there are a total of 60,839 community pharmacies, and these are divided into 22,814 independent pharmacists compared to 21,394 chain drugstores. 8,301 of them are supermarket drugstores, and 8,330 are mass merchandisers. This is according to the National Community Pharmacy Association. In Nigeria, there are many retail community pharmacies premises located in all the states of the Federation. The widespread location of community pharmacies across the country, along with the extended opening hours, is an indication that community pharmacy is readily accessible to the public. Community pharmacy provides a convenient and less formal environment for those who cannot easily access or do not choose to access other kinds of health services like hospitals. Most pharmacies now have private consultation areas specifically for confidential or sensitive discussions, and people can speak to a highly trained healthcare professional, the pharmacist, without the need for appointment. In the United States, this is mandated by OBRA 90 and HIPAA. These are acts that control the patient confidentiality and patient counseling. Who is a pharmacist? Pharmacists are healthcare professionals who practice in pharmacy, the field of health science focusing on safe and effective medication use. The pharmacist verifies the legality, safety, and appropriateness of prescription orders, checks the patient medication record before dispensing the prescriptions, hence the need for computerization and patient profile. This means that the doctor can write a prescription and you choose not to fill, because if there's a problem, you're also liable. I think the law allows it here in Nigeria. The pharmacist ensures that the quantity of medications are dispensed accurately and decides whether the medication should be handed to the patient with appropriate counseling. They are the gatekeepers, because the drugs could cure the patient as medications or kill the patient as poisons. The idea of doctors dispensing is actually not in the patient interest. Pharmacists are the ones that handle drugs, and doctors prescribe. They distribute drugs prescribed by physicians and other health practitioners and provide information to patients about medication and their use. They advise physicians and other healthcare practitioners on the selection, dosage, interaction, and side effect of medications. Pharmacists understand the use, clinical effect, and composition of drugs, including their chemical, biological, and physical properties. There is great need for more improvement with this collaborative effort with the Nigerian physician. One of the panelists will talk more on the collaborative effort. With the development of specific and potent synthetic drugs, the emphasis of pharmacists' responsibility have moved substantially towards evidence-based proper use of modern medications and protection of the public against dangers that are inherent in their use. Their role has evolved from that of a provider/dispenser of medicine to that of a provider of care. Pharmacists are employed in regulatory control and drug management. The community pharmacist's aim is to ensure optimum drug therapy, both by contributing to the preparation, supply, and control of medicines, associated products, and by providing information and advice to those who prescribe or use pharmaceutical products. These are housekeeping. We all know this, but I just reminded you so that if you forgot, you can pick it up. What are the global best practices? The main activity of the community pharmacists are described as 1, processing of prescriptions. The pharmacist verifies the legality, safety, and appropriateness of prescription order, checks the patient's medication record before dispensing the prescription when such records are kept in the pharmacy. ensure that the quantity of medications are dispensed accurately, and decides whether the medicine should be handed to the patient with appropriate labeling and counseling by a pharmacist. In many countries like the United States, the community pharmacist is in a unique position to be fully aware of the patient's past and current drug history, and consequently can provide essential advice to the prescriber. The pharmacist's care of patient or clinical pharmacy stroke medication therapy management. One of the panelists will talk more on this. But however, the pharmacist seeks to collect and integrate information about the patient's drug history, clarify the patient's understanding of the intended dosage regimen and method of administration, and advise the patient of drug-related precautions, and in some countries, monitor and evaluate the therapeutic response, and advise the doctor of any therapeutic duplication, adverse event, and contraindication. In the United States, certain aspects of medication therapy management are billable under Medicare and provided for under Obamacare or the Accountable Care Act. That is to say that when you perform these services, you are paid for the services. I've actually been paid a couple of times for doing that. The pharmacist monitors the drug utilization and does drug review. The pharmacist can participate in arrangements for monitoring the utilization of drug and also in practice research projects and schemes to analyze prescription for the monitoring of adverse drug reactions. The pharmacist prepares extemporaneous preparation and compounding. Pharmacists everywhere continue to prepare medicines in the pharmacy. This enables them to adapt the formulation of a medicine to the need of an individual patient. New development in drug and delivery systems may well extend the need for individually adapted medicines and thus increase the pharmacist's need to continue with pharmacy formulation. In some countries, developed and developing countries, pharmacists engage in small-scale manufacture of medicines which must accord with good manufacturing practice and good distribution practice guidelines. Responding to symptoms of minor ailments, the pharmacist receives requests from members of the public for advice on a variety of symptoms, and when indicated, refer the inquiry to medical practitioners. If the symptoms relate to a self-limiting minor ailment, the pharmacist can supply a non-prescription medicine with advice to consult a medical practitioner if the symptom persists for more than a few days. Alternatively, the pharmacist may give advice without supplying medicine. The key here is to pay attention to the patient, to make him feel important, make eye contact. This will in turn build trust and loyalty. Informing healthcare professionals and the public, drug information resource. The pharmacist can quickly extract relevant drug information, synthesize it, and provide it to other healthcare professionals or patients, and in some cases, to government agencies for regulatory function or policy formulation. If the pharmacist is consistent and up-to-date on drug information, gradually, most of the local physicians and patients will rely on the pharmacy for drug information with its attendant goodwill and hence increased business. These things separate us, the pharmacists, from the patent medical vendors. Disease state management through collaborative effort. The pharmacists can be a great resource for disease state management. They can get certification and specialize on one or more disease states like asthma, hypertension, diabetes, etc. This is prevalent in many independent pharmacies in the United States. Different pharmacies can specialize in different disease states, and they can refer patients to one another. They can offer free laboratory tests at a minimal cost and monitor the patient for appropriateness of medication and compliance with proper documentation. Documentation is the key here. This will bring a lot of loyalty and patronage to the pharmacy. This could also be done in collaboration with a local physician using an established protocol and a well-defined collaborative practice agreement. As approved by state law, many community pharmacies can also collaborate with one another to form a buying group for specific medications from either the manufacturers or importers. This will drive down the price because of the high volume to be purchased. Challenges to the community pharmacies and opportunities to overcome them. Computerization. It will be difficult to be very effective in the above programs without computerization of the pharmacy. The community pharmacies are encouraged to invest on some computer softwares with reference materials like Acromedex, facts and comparison, and a lot more. And also to capture the patient profile for medication therapy management and DUR and disease state management. So it's very, very important that a pharmacy try as much as possible to computerize. Building prescription volumes. This can be a challenge, but with consistency and appropriate marketing to the local medical community about the services that is offered by the pharmacy, the prescriptions will gradually come, coupled with internally generated prescriptions if you are doing MTM or collaborative practices as established in any protocol. Continuing education. There is a great need for continuous training either online or live certification program. This will give the pharmacy practice a great credibility and stand it out from other practices as the pharmacy speaks with great knowledge and confidence. Cost of a standard practice setting. This could be a limiting factor, but starting with what you have available like reference books and also updating your knowledge, especially online, and gradually continuing to invest in other materials. And eventually, the young shall grow. Dealing with the challenges, maintenance of patent medicine vendors. With the ubiquity of patent medicine dealers, it becomes difficult for pharmacists in standard practice, especially at initial startup, to break even. This is actually why there is need to be consistent with high standard, establish trust, and gradually the patient that really need to get well with medication will start patronizing the pharmacy. Despite the apparent high cost, each pharmacy should try to catch a niche, get a percentage of the population that is loyal, and business will start booming. From time to time, bring regulators to perform oversized functions on the PMVs, and due to paucity of funds, a group of pharmacies could sponsor regulatory activities on targeted PMV inspections. Pharmacists in collaboration with PSN, PCN, and state government can fight for pilot programs to establish patent-free cities/zones. There will be need to set up some measurable indices and intermittent survey to show favorable outcomes to encourage government and regulators. The idea here is to say, let's say, take a city in Port Harcourt, in Umuahia, in Aba, and say this area, there will be no patent, and work with the government, with PSN and PCN. And you try a pilot project and say, let's see what will happen to the patient in Umuahia if there's no patent around. Let them get quality pharmaceutical care. Let's test people for diabetes and monitor them, the young, the old, and the middle class. And we collect data and see that the health outcomes of this population have improved tremendously because we have only pharmacies that service that area. It's doable if you just insist on a small area at a time. So if you can have enough data to convince the government that this is in the best interest of the patient, it will continue to expand from city to city. Before you know it, I think we'll get to where we want to get with pharmacy practice. So having got to this point, I will want to talk more on what we see as the 7 best practices for pharmaceutical care. But I'll allow the other panelists to weigh in before I come back to talk about that. Thank you very much.
Thank you very much, Dr. Chris. Let me recognize the President of the Pharmaceutical Society of Nigeria. The President, you're welcome. chairman of Board of Fellows is also here. And yes, welcome. And the brand new secretary of the Board of Fellows. I think we must get back to the theme of why we're here. Best practices in community pharmacy, knowing it and doing it. For me, the questions will be, do we know it or are we doing it? You can't do it if you don't know it. So let's get our minds back to why we are here. Are there a set of values that we can begin to define as best practices in our individual pharmacies and then collectively in our practices? So I'm going to hand over to our national chairman, Dr. Albert Kali, to in 3-5 minutes give us his perspectives on the theme of why we are here. Dr. Akali.
Thank you very much, the chairman of this plenary session. I will appreciate all the dignitaries, the president, chairman, board of fellows, and all the fellows in the house. This year's theme for specific to community pharmacies on best practices, knowing it and doing it, I think it's a good thing that is happening to us. We must look towards best practices. The competition is getting stiff every day. The practice environment is still not what we expect. So for us to stand out as professionals within our respective practice areas, we must adopt global best practices. Today, Dr. Chris has spoken to us, giving us the perspective from the US and the standards that are there. We're going to hear also on collaborative practice, medication therapy management, and disease state management. Now, I would like to quote the definition of the disease state management given by, I'm sure you'll be shocked to know that there is an academy of managed care pharmacy. If you hear of managed care in this country, we will refer only to the medics. But there is an academy of managed care pharmacists. And this academy of managed care pharmacists define disease states as the set of interventions and communications for a defined population of patients where interventions will be carried out to optimize their health outcomes. Now, these interventions are carried out between the patients and the healthcare providers. You as community pharmacists, you are the healthcare providers within your neighborhood. Some of us, I know, are carrying out point of care services like testing of blood sugar levels, testing for malaria parasites, and so many other tests. Now, these tests will help you to be able to guide the patient whether he needs further interventions and to also be able to know whether this patient is complying with his medication. Because by the time you do a test for diabetes and realize that the sugar level is high, on probing you will find out that whether the patient has not been taking or has been taking the wrong doses, and you advise this patient. In that way, you prevent complications that will set in. So we have a one-off task of always updating our knowledge, keeping above board to ensure that we deliver good pharmaceutical services in our respective practice area. Another new concept which will be carried out by, which will be spoken to by Dr. Obe, is on medication therapy management, which is a big one. The disease state management that I've just defined now is embedded in medication therapy management with all the pharmaceutical care processes. Of course, you know that pharmaceutical care involve the process of identifying the various problems associated with prescription medicines, ensuring that we resolve those problems to ensure better outcomes in therapy. So, Chairman, that is my contribution now. We'll be talking more.
Thank you, Chris. I can hear a chair medication therapy management. How do we get pharmacists in every corner of this country to become experts in medication therapy management? Are we it? Do we know it? If we are not, we are going to ask the national chairman to begin to design programs and decide timelines so that by the time we come Ibadan next year, we are going to be agreeing that we have medication therapy managers within us. If it takes piloting, let us do a pilot with a state so that we can become medication therapy managers. I am going to go to Bola to hear your perspectives on the issue of, are we doing it? Do we know it?
Permit me to stand up, please. Good morning, ladies and gentlemen. I stand on existing protocol. My name is Abimbola Adebaki. I think I would depart a bit from clinical outcomes to the action that community pharmacists need to take to run a profitable business. So many of us have left School of Pharmacy or faculties of pharmacy and have begun to practice pharmacy from a totally selfless perspective. But one thing that we have encountered, and I would like to ask the audience here, is less than the desired outcomes of our businesses. Is there anybody here in the hall that is satisfied with the business outcome of your community pharmacy? Anybody? Can I ask the question in another way? Would you want better outcomes from your business practices? Yes or no? Now, in getting to best practice, we must understand what we're grappling with as a community pharmacy. And I'll just take us through something very simple, but because we're scientists, I have found that it is useful for us to look at things from an analytical perspective. As a community pharmacist, you're dealing with a value chain. And that value chain starts from procurement, goes through logistics, goes to inventory management. From inventory management, you need to deal with another perspective of your value chain, which is accountability and control. The next step in the value chain is your people management, and then your brand and merchandising. The last two steps in the value chain that a community pharmacist needs to grapple with are patient interaction and after patient interaction. Is that clear? Those are points along the value chain. Therefore, every community pharmacist must understand how to do the best possible practice along each point of the value chain. So I take it again. Procurement, logistics, inventory management, accountability and control, people management, merchandising and branding, patient interaction, and aftercare. If we're learning anything at all today, it is the fact that what is better that I can do at each point along the value chain? What can you do better with your procurement? How can you get better prices for the items that you are bringing on board? How can you ensure that you are getting safe and reliable products, and that whatever you put on your shelf, you can actually stand by it? That is what you consider under procurement. Under logistics, how reliable is your acquisition of products? How can you beat your chest and tell a patient that I do not have it now, but by 4 p.m. I will have it because my wholesaler and I have a system that I can trust? Are you able to track your orders? Are you able to go online and check when your product is on its way, just like we do with any FedEx or DHL package? The next stage is inventory. I have studied many retail pharmacies, and it is profound the level of wastage we have with overstocking of certain items and understocking of various items. They are sitting side by side in the same pharmacy. So what we are getting is an uneven spread of inventory. There are best practices with inventory management. You need to study your demographics to know what is your own optimal inventory mix. There is something called slow-moving items. What strategies are you putting in place to make sure items that are staying on your shelf are moving every 30 days? That's where I'm talking about best practices. What strategies are you employing to deal with short-dated items? In Edo State last month, millions of naira were they were waiting for NAFDAC to come and help them to destroy goods worth millions of naira. That to me is wastage. What has happened to prevent millions from accumulating over a period? We must put in place best practices to handle short-dated materials, short-dated products, so that amongst us, we have less and less issues of shortages, less and less issues of pilferage, less and less issues of short-dated products going to waste. Best practices must also be put in place for accountability. Many of us right now are chasing after capital to make sure our businesses grow. But that capital will never come to you unless you are accountable for what you have used already. If we were to ask how many of us have our accounts up to date, that is a best practice that anybody that brings capital would expect from you. If you are not accountable for resources, for finances, for even the space that you are using, if your shelves are not profitable per shelf, then what you are doing is you are not running a profitable business. Each shelf must account for its space. If you are using too much of your floor space for items that look nice, but the return on investment is low, you must do a rethink. Accountability goes beyond just finances. It goes even into time and engagement of your community. How well are you engaging the community you are serving under community pharmacy? How well do you know the nature of diseases, like Dr. Chris said? How well do you know the nature of diseases of those